I want to say thank you to Mount Sinai here for putting the symposium together. This has just been a fantastic experience to be here and really inspiring to hear from all these great researchers and all about the talks that we've seen over the last 2 days. Also have the opportunity to see old friends and make some new connections and potential new colleagues and friends as well. So thank you very much. And really it's an honor to be able to close down this in terms of the research side of talks here at the symposium, and really to be able to follow such esteemed colleagues as well. So I'm going to be able to actually build upon some of the great work that we've already heard about over the last 2 days and actually apply some of the experiences that we've heard here. In terms of my talk, what I'm going to do is I'm actually going to be talking today a little bit about GIS, vector-based data sets at the parcel scale, and how we can utilize those as well as remote sensing data sets to analyze built environment, social stressor impacts in urban environments. And while I might say that we're focused on urban health here in the study, we are interested in both urban and non-urban. It's just when we're working in Massachusetts, and I share some of the maps with you, you're going to see that the variation is predominantly, especially with some of the social stressor metrics and environmental ones, is predominantly in the urban environments there. And one of the reasons why we're really interested in urban health is also because of the increased amount of exposure to both chemical and non-chemical stressors, where we see that we're exposed to everything including air pollution, built environment, walkability, light at night, a lot of the things that we've heard about today, including social stressors as well that Mary Lynn talked about this morning, in addition to urban heat island. And as part of my talk today, I'm really going to frame this all around a center that's based out of the Harvard School of Public Health and the BU School of Public Health, known as the Center for Research on Environmental and Social Stressors in Housing, to give applied examples of about how we're utilizing these GIS-derived metrics and remote sensing variables and social stressor data to look at health disparities and health associations. We're going to look at a couple different examples. One is going to be air pollution and infiltration index, as well as green space, where we just heard a little bit about MODIS, and also METAR yesterday, where we heard a lot about the new improved satellites. I'll talk a little bit about that as well. And then also building on the improvement in terms of trying to integrate in not just traditional measures of health disparities, race, ethnicity, but also trying to bring in some of these measures from the index of concentrations of extremes to look at segregation along economic, racial, and educational attainment lines. And then I'll wrap up by talking about how we've now moved on from doing a lot of the independent, one variable at a time models to start to look at multi-stressor and using some newer methods, elastic nets, to do selection of data, lassos, and BKMR. That's really where we're moving. So to begin with, I just want to provide a little bit of background on CRESSH. It's broken up into 3 different projects that are out of the Harvard School of Public Health and BU School of Public Health. The health effects across the life course study, known as HEAL, is managed by Antonella Zanabetti. And then the CRESSH Home study is run by Gary Adamikovitz. And then the CRESSH mapping of environmental health disparities, that's based out of the BU School of Public Health and is led by Patricia Fabian. In terms of what I'm going to talk about today, I'm not going to have time to talk about what we're doing on the home study, but Mizong, who's a doctoral student here, had a poster on it earlier today. So if you've had the opportunity to maybe see that, she can answer some more questions. Instead, what I'm going to really talk about is the interconnectedness with how we've gone about developing a geospatial repository of a number of these different variables and building them at a parcel, block group, and census tract level so that we can do a series of different analyses and attach it to a multitude of different cohorts in Massachusetts with ideas and plans for now we're beginning to scale this up across the United States. And I always like to start off with the CRESSH Center by actually pointing out that it really is a village and not an individual. And if I say something like the we, I really mean the royal we, because it's really comprised of a lot of fantastic people, where it's led by our fearless leaders, Francine Layden and John Levy. And then a number of different doctoral students have contributed on this project. Also, those doctoral students have moved through the program onto postdocs, some postdocs moving on to faculty positions like myself on this study. So it's really been a tremendous experience. In terms of our funders, we're funded by the National Institute of Minority Health and Health Disparities, as well as the US EPA. In terms of the premise behind CRESSH, what we're really focused on is characterizing and mitigating environmental health disparities, and with a focus around housing and built environment, because we really want to focus on things that are modifiable in the environment so that we can work with city planners as well as work with potentially building developers to identify ways to reduce exposure to things like air pollution, or work with urban planners to identify where we could do targeted based interventions to do things such as urban tree planting to help minimize urban heat islands. In order to do that, one of the very first things we had to do over the first couple of years was to develop the highly spatially resolved geospatial data sets that cover a large variety of different exposures and conduct exposure assessments to align this data set with a series of different epidemiological studies. So a lot of the epidemiological evidence using these exposures can then be used to conduct health risk modeling that will allow us to do a lot of the toggling to see how much could be improved if we were to do certain interventions. In terms of the key activities here, to just frame it, we did spend a lot of time building these geospatial repositories, and it was a good lesson to learn because as I've moved throughout the different stages of my career, I've usually been asked to build these data sets one unit at a time, and finding that I'm replicating them pretty, depending upon where I am in which cohort. So we really wanted to derive a method so that we could build this and then provide it as a resource for other researchers that might have interest in working with these data across Massachusetts, or with the expansion now to go to different US areas, to allow for to be really a GIS-based platform to look at these. What we've done so far within our own institutions is to look at inequitable access to and inequitable exposures to different environmental determinants, while also linking this up with 3 different cohorts to begin to look at different health associations. In terms of the health risk modeling, that's the new phase that we've moved into on this side, now that we have some of the publications on the EPI side, to try and see how much we could improve things and if they would have a response potentially on the different associations. In terms of the different data sets that we've compiled, we've really focused on publicly available resources. So bringing in American Housing Survey data, ACS information, creating a lot of GIS-derived metrics around healthy food access, access to parks, both public open space areas as well as private, access to health centers, and then deriving out of those various indices as well around environmental quality, urban heat island, these sort of factors that were created by different doctoral students, postdocs, and researchers on the project. Because the idea was to build things that could be highly reproducible by other researchers across the country, as well as potentially modifiable again. So we could really derive this and work. And then some of the measures that Itai talked about as well, the satellite-derived PM2.5 models, we've been utilizing those as well, and then integrating in both temperature and meteorological from monitors, but also the modeled-based data that Itai and the team at Harvard and other areas have been producing as well. In terms of compiled data sets, we spent a lot of time trying to get these data sets to different spatial resolutions. So everything that you see here, as well as many other data that we've started to compile, in Massachusetts, we have approximately 2.5 million parcels. And what we've done is we wanted to have the idea that we wouldn't have to replicate this for every cohort in Mass. So what we've done is we've calculated these metrics here, the exposure across all the time that we had for every single residence. So as long as you had an address, we could then link it to the existing infrastructure that we have and not have to replicate these steps every time. So it's trying to create a system that's a spatial repository and a spatial bioinformatics center that we can do all this work at. In terms of the different cohorts that we've already applied this to, there's 3 different ones that we've worked with. One is the Massachusetts State Birth Registry data, as well as the mortality data between 2000 and 2015, as well as a very unique data set that is at the Boston Medical Center, where it's a high-risk population of approximately 8,000 children that have been recruited between 2006 and 2015. The majority of this population is low-income minority and has been homeless. There's a high vulnerable population that we can see in comparison to the rest of the Massachusetts birth registry information impacts to see if they're the same in our more vulnerable areas. So what we've done is we've geocoded each one of these, and we're very meticulous with geocoding. It's something that I really love to work on, and we want to make sure that we are at as finest resolution we can. So we really focus on parcel-based and point address systems before doing street network, and doing this within a locked environment, not doing this in terms of servers that are across different corporations where you'd have violations of IRB. So doing all this work in-house within BU in Harvard. Sorry about that. One of the first areas I want to talk about how we've utilized the vector-based data is really vector and remote sensing data is really the combination of looking at PM 2.5. A lot of different people have utilized ETI's models and the work that Joel and everyone has been doing, as well as we've combined this with the NO2 models from Petros Katrakis. The very first thing we wanted to do, though, was look at how PM 2.5 might be impacting the populations that we have in Massachusetts. And we saw strong relationships with birth weight and mortality, but I want to share with you some of the unique results that we see when we work with our more vulnerable greater Boston area-based population. Now, this is that population from the Children's Health Watch study that has a high degree of the participants that have been homeless, and you can easily see that PM 2.5, it has some association with birth weight, but really the major driving factors when we're working with these vulnerable populations is overwhelmingly if they've been homeless at any point in time, or also if they're on WIC or SNAP. And this really drives at trying to do research that could be focused on modifiable things, either at the individual or community scale. Identifying, yes, we are predominantly environmental health researchers. A lot of us have a background in air pollution between the BU and Harvard team, but this was a very important find, and especially since some of the changes in policy that have been put in place about whether or not we'll have potential attrition in terms of a point system for being able to gain citizenship if you take part in these publicly available programs. So we're very concerned in places like Boston about people if they're not from the United States and they're not willing to take part in these programs that are obviously very important to the health of their young children. So this data is being used to help support that with our community partners at the Children's Health Watch to help identify key risk factors that can be modified based upon policy solutions. Another piece I just want to share is sort of the application of the PM 2.5 with NO2. What we're looking at here is change in population-weighted PM 2.5 and NO2 by census tract ACS, and we're looking at race, ethnicity, as well as educational attainment and income. And we can see over time that there's been a decrease in PM 2.5 and NO2. The dashed lines represent rural areas in Massachusetts, and the solid lines represent the actual urban-based changes in PM 2.5. And I'm just going to hone in here just quickly on the NO2 to show you sort of the patterns that we've observed here that have been done by Anna Rosofsky, a former doctoral student at BU that's now working at the Health Effects Institute. This is really some great work she's done to identify that in Massachusetts, while there's been a decrease in overall PM 2.5 and NO2 over time in all race ethnic groups as well as the income groups, that difference in the population, though, has remained stable. So what we see here is that bottom line of the solid line there, that's actually the non-Hispanic white population, and then the top line, the blue line, is actually the Hispanic population. Both are decreasing, but that inequitable exposure pace has been remaining the same over time. We see a very similar trend when we look at income, as well as with educational attainment. Those that have higher income have lower exposure. Those that have higher educational attainment have lower exposure, and that slope difference remains the same. However, as Mary Lynn said earlier, the race ethnicity piece is not a modifiable variable. So when you go and want to work with your community partners and talk about what could be solutions, one of the things that the research team has been doing is focusing on home-based aspects that could be improved, such as air exchange rates. So infiltration index, that's one potential modifiable aspect that could be used to reduce exposure to air pollution. And what we can do is we can model out, Anna Rosofsky again modeled where we could see air exchange rates based upon utilizing census data, tax parcel-based information, as well as modeling for indoor-based environments. So compiling both the GIS data as well as model-based information, what we can see is at the parcel level, each one of these little areas represents a different residential parcel in Massachusetts on the left with a zoom in for a Boston area to really get an idea of the difference here in air exchange rates. And the idea here is that a higher air exchange rate actually would lead to higher ambient air pollution exposure. And this is also not taking the assumption also that there's indoor sources as well. So this is focused on ambient air pollution and also wanted to reduce the air exchange rates so you could reduce the exposure to the ambient side. We map this data to then see, against, again, race, ethnicity, income, educational attainment, whether or not areas that have high air pollution as well as high air exchange rates, so the worst of both situations, whether or not there were differences in the demographic profile of those populations in the 90th percentile of each versus the lowest in terms of lowest PM 2.5 as well as lowest air exchange rates, having the best in terms of indoor reduction in ambient exposures. And you can see here that that dark black line that goes from left to right in a downward manner, that represents the non-Hispanic white population. And then you can see that's predominantly about 90% of the population is non-Hispanic white that has the best of both, the lowest air pollution and the lowest in terms of the air exchange rates. However, when we switch this around and look at the highest, what we see is that's when we're starting to observe their differences. And we can see that this is really important because an air exchange rate, that's something that housing authorities can work on. So there's been a lot of work in Boston as well as many other areas working with HUD as well as with the Massachusetts Public Housing to create a more tightly sealed building, create policies to reduce indoor air exposures or sources of that, such as smoking as well as gas cooking, so that we can have lower indoor, tightly sealed buildings, because sometimes we're not going to be able to fully move all the public housing pieces, but we can act upon a modifiable piece and do targeted based if we know where there's the high air pollution and the high air exchange rates. In summary for this piece, one of the elements that we really are focused on, again, is using these publicly available geospatial data sets to look at air pollution health disparities research, as well as to expand the epidemiological evidence around interactions, especially around modifiable based elements such as housing structure or other aspects that could be improved in the environment. The next part of my talk I'm going to do is talk about how we were utilizing greenness and green space to look at health effects as well. We've already heard a lot about the different satellites, so I'm not going to spend a lot of time on this. We also have been utilizing MODIS, VIIRS, as well as looking at inclusion of Landsat-based information. So there's been a huge increase in terms of the spatial resolution of these satellites, and I'll show you sort of the applications of that and how it can really improve exposure assessment in just a minute. But in terms of this piece, what I'm going to do is really focus on what we're doing in the green space area, especially around measuring and modeling of greenness using MODIS and Landsat. In terms of remote sensing data, I'm not going to go really into detail. Matar provided a great explanation of how this is all done, except to just really explain that what we're looking at here is the normalized difference vegetation index, which is a very common measure that is, as it's coming from satellites, it's available globally. So that means studies that look at green space, cardiovascular health impacts in one area of the world can be compared to other areas as well, because it's that standardized metric from one source. And what we're looking at here is the ratio of the infrared to visible light-based spectrum. But what really is that for those that don't really work in the green space area? What we're doing is we're really building upon the Wilson biophilia hypothesis, where we've had innate evolution towards one affinity to nature and to organisms out in the environment. And as we move to more urban-based environments, we spend our time indoors more and more often. What we have is a lack of exposure to nature. And how can we actually capture that? And trying to think about some of the mechanisms of action by which greenness may or may not be impacting that. A lot of the studies that focus purely on NDVI have found associations with things like birth weight, mortality, depression, depressive symptoms, with some mixed findings when it comes to cardiovascular disease and asthma. Some of these might be due to, if you're increasing asthma, increase in greenness, you actually have increased exposure to other allergens as well. So that led us to think also about, what are the mechanisms of action around this? And typically greenness, it can have both indirect as well as direct effects that you could potentially measure if you have different parameters in your model. So some of the indirect effects would be that it can mitigate and reduce air pollution as well as urban heat island temperature impacts. And some of the direct effects, some of the research that's being done looking at different brainwave and cortisol levels and blood pressure in individuals when they walk through green parks or if they're walking along different streets, is starting to show that it could work in a rumination where you're decreasing the stress levels of people when they're actually in a nature-based environment. In terms of the NDVI measure, just to give a little bit more background for those that are not familiar with this measure, it is on a scale that goes between -1 and 1, and values that are 0 and going below are typically water-based as well as asphalt areas. And what we typically do is mask those out, or some research studies set them to 0. What we also do is we built this analysis to use both MODIS, which has 250 meter resolution, and Landsat, so we could do comparisons. There's some very interesting work I'm not going to be able to talk about today or share in detail around how you go about assigning exposure to greenness and really testing it based upon different ways, such as buffer-based exposures, or if you use something that would be an individual's identification of where they actually perceive their neighborhood to be, and identifying that you end up with different health outcomes based upon how you actually characterize that. If that's an area that you're interested in, you should really check out some of the great work that's being done by people like Colleen Reed, as well as Jane Clordy's group that has published a couple papers on this topic, and it's been really, really great to see. We download all this data and we average out NDVI across every single parcel in Massachusetts at different buffer scales, as well as access to parks as well. So when we talk about greenness, we're typically thinking about the level of greenness around a residence or where you'd go in close proximity to your home, as opposed to the actual activity base, which would be going physically to a park or an area that is green, and then simultaneously potentially getting physical activity. We're going to be focusing here on the NDVI changes and how we can use them in various ways. With these data sets, we've been able to look at long-term changes over time in greenness at various different cities. And to use this and put this information out, we actually have an online data visualization website within ArcGIS Online that's publicly accessible, so that people will actually see the changes in their own environment out there. So this will allow urban planners to then be able to identify, okay, if we're going to do tree planting campaigns, maybe we need to do them in certain areas. Also using it for epidemiological evidence as effects in our epidemiological studies. This work has been done by Kelvin Fong while he was a doctoral student at Harvard School of Public Health, and then now has become a postdoc doing some of this work with Michelle Bell's team at Yale. And here what we do is Kelvin mapped the association where you could see for a change in greenness what was the corresponding change in birth weight, and really found that if the greatest response when you do the GAM plots here is in areas that are less than 0.5 for NDVI. So this is really showing that you have different exposure response functions and stronger effects that can occur in the lowest greenness area. So if you have tree planting that you can do in your urban environment or in other locations, it's really beneficial to increase that greenness in the areas that have low to median levels. We might think like, oh, that's pretty obvious, but a lot of times there's different offsets or reasons why it might cost more to put them in those locations. So having this evidence that you can share with the community partners as well as with local officials that make those local-based decisions is really an important piece of evidence on the health side, but also being able to show them the maps of where they could do it as well. We also have used this data, Mayan, another postdoc that's on the project, used this to look at the impacts of greenness by different trimesters, and found that there really wasn't a difference, but it was always significantly associated with birth weight, regardless of which trimester you were in. And where are we going with greenness? We've heard a lot about these satellites that are coming out. I'm really excited about this with some of the new ones that really are going to have really fine scale spatial as well as temporal resolution. Because when we look at MODIS, and here what we've done is on the left-hand side, I want to thank Raquel Jimenez, a doctoral student at BU, for putting this slide together. It really does a fantastic job of articulating this point. Is what we see here on the left-hand side is the Boston Commons and Boston Public Gardens. And you can see the pools of where the water are located. And then on the right-hand side, these are the different grids that would overlay with that park. And we can see if you're using MODIS 250-meter grids, you're going to get potentially a lot of exposure misclassification if you're calculating out parcel-level exposures. As you begin to move to Landsat, which has 30-meter, now you can see some of the outlines of the roads, a little bit of the parks, a little bit of the ponds themselves. Moving to the newer satellites that are becoming available with the data is really tremendous, because now we're getting down to 10 meters. We can very clearly see the patterns of exposure that exist in a more highly spatially resolved way. That would be improvements in terms of exposure assessment. And then moving even further into utilization of NIAP flyover data. This is flyover information, but it's not as temporarily available. It's really great to see that the newer ones are going to even be able to provide within-day measurements of some of these things like land surface temperature at high spatial resolution. So we can overcome some of the major difficulties of using remote sensing data, such as cloud cover issues, or also the resolution of the data if you're doing health analysis that could result in from exposure misclassification. But it's not just utilizing these in Massachusetts. As I said before, these are standardized measures available everywhere across the globe. So collaborating with various different groups, some of them in Seoul, Korea, we've been able to look at how heat mortality is being mitigated by greenness measures. Also, we can utilize the same exact satellites, including things such as impervious surface area and nighted light, to look at cardiovascular health impacts in places like Chennai. So these measures could potentially, with these outcomes, be compared against other studies across the globe because it is a standardized measure. And similar to utilization of the global burn disease PM 2.5 model. So as GBD has moved into utilizing the data that comes from Randall Martin's group at Dalhousie, now we have a standardized metric for PM 2.5 across the globe. If we wanted to look at green space analysis or greenness health impacts, we could also do that because we could all use the same Landsat or MODIS data set in Seoul, in Chennai, and in Boston and New York. In summary, satellite data is really widely available, and this area is really growing. In terms of how you can go and get this data, it's publicly available. You can get it in a couple different ways. Earth data, that's where you can get more of the manual download and process. Also, Google Earth Engine is one way to be able to obtain some of the data in a more systematic, quicker process and environment. However, not all the new satellite data is available on the Google Earth Engine yet. Cloud cover is a major issue. It impacts temporal availability of the data, and it's typically spatially correlated. Now, this is a really rapidly expanding field. We've seen, if you attend any of like the International Society for Environmental Epidemiology conferences, there's been a massive increase in the total number of sessions that have occurred just over the last 10 years. So it's really a great growing field, and it really has to do a lot with the availability of NASA as well as other government-based satellites. The next topic I'm going to talk about is segregation and integration of some of the metrics that Marilyn talked about this morning to us about racial isolation. And I just wanted to share this because it's really a nice area that's been expanding, and here's a series of different papers that really influenced my thinking about moving away from traditional health disparities metrics like race, ethnicity, income, and educational attainment to look at sort of the context of whether or not certain groups are being isolated instead. And you can see here that some of these are being applied to a multitude of different environmental exposures when it comes to health disparities, because these are data sets that are available through the American Community Survey. So anybody can take the equations and take the publicly available data and start to integrate these same measures. In terms of the ones that we're utilizing, they're slightly a little bit different than the one that Marilyn showed this morning, but they're similar type of premise. This is the index of concentrations of extreme, where I'm sharing with you the equation for economic residential segregation. And what it's doing is trying to get at sort of the same premise. Whether or not you have isolations of low income and high income populations versus well-mixed groups. And when it comes to the ERS, what we're doing here is we're measuring the number of people in the percent of the population that is greater than 100,000, making less than 20,000 per year. And the way you interpret this metric is that values that are -1 are going to be those that are isolated communities of low-income individuals making less than 20,000 without anybody that makes in excess of $100,000. As you move towards 0, what you get towards is a more well-mixed population of both low-income and high-income population. As we move towards a value of 1, what we begin to see is population, census tract block groups that are isolated in terms of high income, those making in excess of 100,000 per year without anyone that actually makes less than 20,000 per year. The other population number groups between 20,000 and 100,000 are not a part of the actual calculation. You just want to see how well mixed the low income and high income groups are together. So it's different from if you were trying to map median household income, like you saw before, had all the different characterizations. You can see in Massachusetts that we do have some different cluster pockets here that are both urban and non-urban when it comes to ERS. We can map these changes over time. Now I'm sharing with you the racial residential segregation. And I was really excited to see Marilyn's map earlier about racial isolation. This is one of the difficulties about doing this metric in a place like Massachusetts, where the population is predominantly dominated by non-Hispanic white. And what we end up seeing is that most of the variation is entirely within urban-based communities here in a state like Massachusetts. But we can actually measure these and see changes over time. And I'm very excited about what's going to happen once the 2020 data is available, because then we'd be able to see changes based upon potential gentrification issues in places like Boston and other areas where we've seen population shifts in places like Chinatown, Boston, where I do a lot of my other research with ultrafine particles. And what we see there is that there's been huge high rises being developed in what originally were low-income areas right up against the major highway systems of I-93 and I-90, and that has really changed over time. We also took these measures and wanted to see whether or not there were differences based on exposure to greenness. So we can combine this with our remote sensing data. And when it comes to ERS, what we observed was that there's a nice linear trend as we move to the lowest income isolated groups on the left-hand side to the high income group on the right-hand side. So the populations that are making excess of 100,000 have significantly higher exposure to greenness than the populations that are lower in terms of isolation of low income. When it comes to mapping the racial residential segregation exposure to greenness, we see a very different relationship in Massachusetts. What we see is that, again, the isolated white non-Hispanic population has the highest exposure to greenness, but as we move into the other areas, moving into isolation, it's really a quick fall off, and there was not a big difference there. So the populations, again, given the dynamics of Massachusetts, they play a role in potentially why we see these different type of relationships between race ethnicity versus income-based segregation measures. We've also utilized them to look at their independent effect on things like birth weight. This work has been led by Kelvin Fong again, and what we see is if we utilize the reference group of the population that is in the lowest categorization of economic residential segregation, it is lower than all of the other groups as they move towards well-mixed. An interesting finding here is that the group that is the highest income isolation, moving towards that, the 0.6 plus, that actually drops below the more well-mixed population groups here, creating a interesting follow-up analyses based upon the age stratification of those populations as well that we're exploring. The final piece of my talk I really want to talk about is the multi-health stress analysis. So as we compiled all these different data sets, we've looked at health disparities. We have a variety of different measures that we can look at birth weight in relation to our Children's Health Watch data, or also mortality across the state of Massachusetts here. Combining each one of these, we've already started to look at individually or in tandem one or two of these exposure variables while controlling for all the individual risk factors and other community-based factors. And then in some cases to begin to look at 3 at a time. But really what we need to do is move towards a fully integrated approach. And just to share with you just a quick idea of what we're doing here, we're utilizing things like BKMR as well as LASSO to deal with some of the nonlinearities as well in these different data sets. But as we move from a single exposure model health analysis on birth weight, what we begin to see is that PM2.5, in the different trimesters was significant when we were treating it as our primary environmental exposure. But when it's in the model with all these other variables that were selected, it begins to lose some of its importance, at least in the Children's Health Watch-based analysis. So as we begin to include temperature, that remains relatively the same. Walkability has a slight decrease. Measures like NDVI, this is interesting because NDVI had, it decreased by approximately 3 to 4 times its association once we went to the multi-exposure model. But that makes sense because it has both direct and indirect pathways. So as we moved away from the single pollutant model to the multi-pollutant, we're actually now with a model that controls for temperature. It's able to control for that indirect pathway. The air pollution is in the model. That can control for potential greenness pathway and start to delineate what might be the true association here between greenness and birth weight. And what does this all mean? What we're trying to do as a group is be able to develop a publicly available GIS-based repository here that allow for characterization of a multitude of different chemical and non-chemical stressors while building out the epidemiological evidence to support that these are really complex interactions here between the physical and social environment. And that, what we're seeing here is really strong evidence as well for racial and socioeconomic disparities that go beyond just the traditional measures of health disparities as we utilize these segregation metrics. And where is all this going? I'd just like to finish up with this aspect. I really like that Mayor Lynn talked about sort of taking this data and putting it out there for people. It's really one of the key aspects that drew me back to want to really work on GIS-based development. As we build all these measures, I'm not sure if we can get that, Carla. Yeah. So one of the things that we're trying to do with the CRESSH study, as well as at the other center I work at, is take these data sets and put them into an environment that is searchable. So we've put this out there and had webinars with community members, policy people, nonprofits, our community groups, so that they know this is available and they can actually utilize the indices and measures that we've been collecting in a map and environment themselves. So the idea here is, while we're I'm using ArcGIS Online just because it's very simple for us to use, and we don't have all the bandwidth to develop the data visualization systems ourselves. But one of the key pieces here is to make this data easily available, different data sets, and not always just the shapefiles or the geodatabases, but in an environment that community partners and other people could search and put into action. Can we just go back to the slide, Sunfish? Thank you. So, oh, there we are. Thank you. And while I've shown everything here from Massachusetts, one of the key things I want to say is that we're taking this data and trying to expand it across the United States. We really want to think, at least we think about it internally as a group, to really think about being a platform that other researchers should feel open to coming and talking to us about whether or not they would be interested in the data for Massachusetts or helping to develop it for other areas. And many of these data sources we've started to expand across the United States. And also, Marilyn talked about metadata. I feel like I'm just following right off all the great things she was talking about. The idea is, as you scale this up from one state into trying to do the entire United States, you have to have automated procedures for this. So a lot of the stuff that we're doing is enacting very strict sort of protocols, QA procedures, as well as SOPs, so that we'll have really fantastic metadata to go with the information. Especially if we plan to share this, we want to make sure that it's something that we would be very positive about other groups using. And currently at the Biostatistics Epidemiology Data Analytics Center where I work, we've started to do some of this with CRESSH and start to build. And that original photo was of Massachusetts, and now we're trying to think of it about being across the United States and trying to build these out in a shared system so we can work with not just community partners, but also with other academic partners as well. So I just want to thank you for staying and listen to my talk. If you have any other questions, please visit the CRESSH website. Also, there's our Twitter feed as well. I'd just like to say thank you very much for inviting me today.